Hi Calgary residents, so I'm back with the Dare to Diagnose 2 answer. And yes, Uncle Sam wants you. This little video will show you quickly how to diagnose it, what the background pathophysiology is, and why you should care. I think you'll find it useful to invest 5 or 10 minutes into looking at this information. So what is SAM? So SAM is systolic anterior motion. That means this part of the mitral valve, the anterior mitral leaflet, moves into the left ventricular outflow tract during systole. So what you would expect during systole is for that mitral valve to be nicely tented here, and this outflow tract to be wide open. Okay, so on echo, this is kind of what you will see. Okay, now usually when you look at it, you'll see the left ventricular apex on the top of the screen with the atrium at the bottom. You will see the mitral leaflet flipping into this aortic outflow tract and causing an obstruction of flow here. And this is what that will look like on your echo picture. So we've turned it, so the left ventricle is now here. You have your mitral valve, your aortic valve, and then that leaflet bending into the outflow tract. This is how it would appear on your parasternal long. So you'll have your atrium here with your ventricle here going into the aorta here. This is your aortic valve. And you have this leaflet, the anterior leaflet, pointing into the outflow tract here. So the secondary effect of that is as that mitral leaflet points into the outflow tract, you will get turbulent flow going through the outflow tract, implying sort of a pressure gradient and an obstruction to flow. And what will also happen is that in some people, as that mitral leaflet gets sucked into the outflow tract, it will no longer coapt. So your posterior leaflet and your anterior leaflet will not meet each other, and you will get flow, mitral regurgitant flow coming into the left atrium. So that is what that would look like on your apical 4. And this is what it would look like in your parasternal long. So you have your left atrium, your left ventricle. You'd get that anterior mitral leaflet pointing into the outflow tract with turbulent flow going this way and mitral regurg flow going that way during systole. So our next thing that we can use to diagnose is M mode. So I just want to remind you again what it would look like in your parasternal long, because that's what we'll be using that M mode to make the diagnosis to help our eye. You would get this mitral leaflet, instead of being nicely coapted to the posterior leaflet up here, pointing into the outflow tract. And this is what the echo picture would look like: aortic valve, atrium, mitral leaflet is supposed to be closed because it's systole, not diastole. So mitral leaflet is supposed to be closed, and this outflow tract is supposed to be open, but you're seeing this anterior leaflet just pointing into it. Now, what does a normal M mode look like? So when we teach our course, we teach you to look at this, to look at this part and how that mitral valve opens. That gives us a sense of cardiac output. The mitral septal separation. So you have looked at this M mode before when you've done the course. And this is sort of the normal pattern that we would see. You would see E and A. So this is passive inflow and atrial contraction. So you have these two little nubbins. But then during systole, your anterior and posterior leaflets should meet in the middle here, the mitral valve. And this outflow tract should be nice and open. Now, so if we do a schematic, you'd have systole here and a very nice open outflow tract, and yet in diastole you'd have your E and your A. Now, what happens during systolic anterior motion of that mitral valve is you have your E and your A, but then you have movement again. So systolic anterior motion, and you can see that on M mode. So this is what it would look like if you're actually recording the M mode. I'm reminding you again what M mode stands for is motion over time. So these are all the different structures of the heart and how they move over time. This would be the septum. This is the left ventricular outflow tract, and this is the motion of the anterior mitral leaflet and the posterior mitral valve leaflet. So during diastole, the mitral valve opens nicely. and then it closes, opens, and then it closes. Okay, now here, this looks different. So again, during systole, so you can actually, if you don't have an ECG, which we sometimes don't have, you can track systole by looking at the right ventricle here. So if you'll think about your parasternal long view, you have right ventricle, wall, right ventricular lumen, then you have septum, and here it's kind of a hypertrophied septum, so probably a HOCM patient. And you'd have your passive inflow, your atrial contraction, and then this is no longer that nice smooth flat line that we saw there. We have this blip where that anterior leaflet moves into the outflow tract. Okay, and if you see a gap here in between the anterior and posterior leaflets, that would mean that you would have MR. So this is what the M mode can help your eye look at, is whether that leaflet stays closed in asystole or whether it moves. Okay, so I'm going to play the loop from our that we sent out, and I want you to keep an eye on this area here. Let's loop it. Okay, keep an eye here. Look at what's happening to this mitral valve leaflet. Do you see how during systole it's bending into that outflow tract? Okay, bending into that outflow tract. Okay. And now just to remind you what color we should see. When we play that, we're going to see turbulent flow going this way and flow going that way. So we have our aortic stenosis and our mitral regurg happening at the same time. And there we can see it quite clearly. Play it one more time. So how does this happen? So most of the time when I talk to you guys about SAM, what I hear is HOCM. Now HOCM is definitely part of this, but it's not all of it. There are lots of structural and geometric reasons that the heart would be predisposed to it, HOCM being one of them. And HOCM is also not the only reason that you'll have a bulging septum. Some elderly people, just the way their septum's kind of, it's sort of like a degenerative way that the septum moves during old ages. It becomes this kind of hump that then generates a narrowed outflow tract with a bit of a venturi. And if you then have a kind of degenerative myxomatous mitral valve, it can just get sucked into that outflow tract. So SAM isn't always HOCM. HOCM is a small part of SAM. HOCM is not really the most important one for us because patients that have been diagnosed with HOCM, we usually know that they have HOCM. It's the ones that come with a predisposed heart that we don't really know about it. And then we do some of this unmasking that then triggers the systolic anterior motion and the left ventricular outflow tract obstruction. Interesting is that diabetic patients seem to be quite predisposed to it. They've looked at it, and the incidence is significantly higher in diabetic patients. Now, the unmasking that we do during the operating room, states of hypovolemia, vasodilatation, and include, especially if we start adding inotropes to that, will significantly exacerbate our SAM and our left ventricular outflow tract obstruction, as well as our mitral regurg. I'm not going to go into all of the structural and geometrical anomalies. If you are interested in it, the reference that I've given you up top in the Cardiothoracic Surgical Journal has some of that information in. So in summary, SAM is a complex disorder. It causes the mitral valve to shift anteriorly during systole, and this leads to both a dynamic left ventricular outflow tract obstruction and mitral regurg. The mechanisms are not fully understood, but it includes some pathoanatomical dysfunction relating to the mitral valve. It is classically observed in HOCM, but it can also be observed in a wide spectrum of underlying diseases. And our current diagnosis is based on detailed either echo or MR, and our current management goes through a range of medical to surgical options. And this is kind of a little bit what that looks like. So what are the causes? So HOCM on this side is almost always requires surgical repair at some point. Post-surgical really depends on the severity. And metabolic, and this is usually where we are, this is the kind of patients that we would be managing, really can often be managed with conservative management. And what is conservative management is volume expansion, beta blockers, and discontinuation of inotropic drugs. I want to just draw your attention to the fact that the grading of SAM is dependent not only on the LVOT gradient, which we always quote, but also looking at the degree of mitral regurg. Those two really go hand in hand. It's a combined pathology. So why should you care? Well, you should care because it has significant implications for your anesthetic. So SAM is often confused with an obstructive cardiogenic type shock because you'd have high filling pressures because of that obstruction in the outflow tract. And this is often then treated by trying to decrease preload and afterload and either leaving contractility the same or trying to improve it. The other thing that is often seen as a conflict is the mitral regurg. People will look at this patient and they go like, oh, this patient has terrible MR. And what are our hemodynamic goals for MR? Well, we want to keep the heart rate up, we want to keep the preload low, we want to keep the afterload low, and we want to keep the contractility off, which is completely the opposite of what you need to do to manage systolic anterior motion. What we want to do to keep that mitral valve from flipping into the outflow tract is to decrease the heart rate, increase the preload, increase the afterload, and decrease the contractility to stop that hyperdynamic Venturi effect from escalating. And so knowing what you're actually dealing with, whether the mitral regurg is the primary pathology or the systolic anterior motion of that mitral leaflet, is the reason that the mitral regurg is becoming a problem and that you therefore should focus on the SAM, is very important to target your hemodynamic goals accurately. So please do think about it when you have a low blood pressure that is not responsive to other treatments. And I would add that to my list of secret blood pressure droppers, which includes always thinking about anaphylaxis, air trapping in patients with COPD or asthma, some hidden hemorrhage, or a possible underlying endocrine condition. And that's it for today, guys. Thanks for listening, and thanks for playing Dare to Diagnose with me. Continue to focus on your POCUS and have a good time with scanning.